Hey guys, Mike Laurie here. I am a critical care flight paramedic with the Dartmouth-Hitchcock Advanced Response Team, soon to be EM resident at the University of New Mexico, and regular contributor to the MCRIT podcast. And this is The Case of the Dying Soldiers, a talk I gave at the Critical Care Transport Medicine Conference 2018 down in San Antonio on practical applications of pharmacology in critical care transport. So I have nothing to disclose. I have no conflicts of interest. But this talk is about practical applications of pharmacokinetic and pharmacodynamic principles in the critical care environment. And I think this is important because generally, whether you're getting trained as a paramedic, a nurse, or a medical student, we talk about really important aspects of pharmacology in these very lofty, ivory tower, inaccessible ways. We throw complex equations and graphs at people about half-life and loading dose, and we really don't think about how can we present this information so people will learn it and will be able to have it at hand at 2 or 3 o'clock in the morning when it's really, really important and they have a dying patient at their side. So I think what we really have to do is rethink the way we've taught some of this stuff. And I think we need to present it in a way that people can wrap their heads around. I think we can do this in a couple ways. First, we can help people understand the salient aspects of the pharmacology. Then, teach people to think about the physiology in front of them. And finally, apply a very high fidelity mental model that can help people decide on therapeutic adjustments on the fly. And so to start out, I will use the example of rapid sequence intubation, which is, I think, germane to the critical care transport environment, as well as the emergency medicine and critical care environment, as an example to talk about some of the pharmacology. So this really came to the forefront of my mind when I was back in the military as a pararescueman, and I was in a deployed setting and had a very sick patient that I needed to take care of. So a patient, the polytrauma patient with a closed head injury and a marginal hemodynamics, a blood pressure that was systolic blood pressures floating in the high 90s, low 100s, heart rate in the 120s, otherwise healthy military age male patient. And in order to manage his airway, we decided it was appropriate to perform RSI, and I did what I was taught was appropriate. I decided to use ketamine, which I was taught was a quote unquote safe, hemodynamically stable agent that would maintain blood pressure or perhaps increase blood pressure and heart rate. It was the go to agent for trauma, and I was following what at the time was our guideline, which said give the patient 2 milligrams per kilogram of ketamine for induction. So that's exactly what I did. I gave him 2 milligrams per kilogram of ketamine for induction and the appropriate dose of the muscle relaxant. And being that he was an otherwise healthy military age male, I got the tube in no problem. I was super proud of myself and ready to high five everyone around me when I looked up at the monitor and I saw this. My heart immediately sank because I was like, oh my gosh, what is going on? I looked down at the patient and he's kind of grayish and not looking so hot. And I was like, hey, can we run another blood pressure? Well, the blood pressure cycles and cycles and cycles, and then it gives me the dashes of death. And I get really, really worried. My heart rate went through the roof and my sphincter tone also went through the roof. Luckily, we felt really quickly for a pulse, realized he still had a pulse, and it was really because of the amazing team that I was with that we were able to get him lined up, get some blood going, use a little bit of push dose epi to get us through, and we were able to restore hemodynamics, get his blood pressure back up, and appropriately resuscitate this patient, as well as provide the appropriate therapies for his closed head injury. But it was really scary, and it was a very close call. I thought I had just had my first clean kill of a patient, and I really, after that experience, went back and started to think about it. And if I had done my homework more carefully, I would have realized that The military had learned this lesson in another war on the other side of the world. So December 7th, 1941 was a day that will live in infamy for a number of reasons. This was the day the Japanese attacked Pearl Harbor, one of the single greatest or worst tragedies in the history of the United States military. Many, many service members lost their lives, but actually, many more would have lost their lives had it not been for the heroic efforts of an amazing group of physicians, medics, and techs at Tripler General Hospital on the island that day. But what we actually don't talk about or don't hear about that often, is some of the unfortunate misadventures that happened in the OR that day. So, according to a number of accounts, there were reports of patients, a number of patients dying on induction of anesthesia. And that was because at this time in history, the United States had recruited civilian physicians, civilian anesthesiologists, and surgeons to come into service. And at this point in the history of anesthesia practice, thiopental had recently been introduced as a IV agent that could rapidly induce amnesia and unconsciousness, and was being used widely in civilian practice, but for hemodynamically stable patients. So, according to these various accounts, when normal doses of thiopental were given to hemodynamically unstable patients, they went into respiratory arrest and coded on induction, which was very unfortunate. So while this event basically signaled the entrance of the United States into World War II, it also began a brief war on IV anesthetic drugs. A number of publications came out. Of note, this was probably the most well read or most widely distributed, which was a critique of intravenous anesthesia in war surgery by F.J. Halford, who was actually a surgeon who proposed or who gave a scathing review of the use of IV anesthetic agents, actually referring to them as, quote, an ideal method of euthanasia. As you might imagine, this met with swift and vociferous retort from the anesthesia community. And eventually, they were able to get to the bottom of things and discuss it, and it led to the silver lining around this very unfortunate cloud, which was a better understanding of the kinetics and dynamics of various IV anesthetic agents. And the anesthesia community did the right thing and began a series of investigations to better explore these agents. And this led to and better understanding of the pharmacology. So, not long after World War II, Price did a very interesting review of the effects of distribution of thiopental in the human body as a function of physiologic condition. So he looked at the distribution of thiopental under conditions of normal perfusion and after hemorrhage. And what he realized was that a much larger percentage of the medication ended up in the central nervous system. And this was followed later on by a number of studies that looked at similar things. So, this was a study by Johnson and colleagues that looked at the effect of shock on propofol concentrations in serum. So, they gave a standard infusion of propofol in animal models. They used porcine animal models, and they compared the ones that were or had normal hemodynamics to those that had been bled a certain amount and were in shock. And what they found was that there was a higher peak concentration in serum of the patients that were, or the animal models that were in shock, and this effect persisted for quite a period of time. So when we look at, or we would consider the instance of bolus dose IV anesthetic agents for induction, we look at the kinetics and it looks something like this. Imagine pushing the anesthetic agent, so pick your drug, and it goes through the it goes through the venous circulation, hits the heart, and is immediately distributed around the body, and serum concentrations rise to peak. And then, as you'll notice, they start to fall off very quickly. And this effect is due to what we call the T1/2 alpha. And the T1/2 alpha is the half-life of redistribution. So remember that these drugs, after they enter serum, they not only go to the brain and other vital organs, but they redistribute very quickly into muscle and fat. So that's why the concentration drops off very quickly. And we see a lot of these agents that are used in rapid sequence intubation, they wear off relatively quickly. And then, as you notice, the concentration kind of tails off over time. And this is due to the T1/2 beta, which is actually the metabolism and clearance of the drug from your body. Now, let's take, for instance, the situation of a patient that's in hemorrhagic shock. Okay, so here's our patient in hemorrhagic shock, and you'll notice a couple things about the differences between the kinetics, the difference between these two lines. First, the patient that's in hemorrhagic shock, there's a delay in peak serum concentration. So it takes longer to reach peak serum concentration. The peak serum concentration is higher than the patient who's not in shock. The medication does not redistribute nearly as well as the patient in shock. And you'll notice this effect persists out much longer. So you'll have higher serum concentrations for a longer period of time. So why is this? Why these changes in kinetics in the patient in shock? And in order to understand that, we have to really think about the physiology. And when I think about the physiology of shock and how it changes the kinetics of different medications, I kind of lump those effects into two categories. The first is cardiovascular effects. So in shock, we see a couple or a handful of things. First, low cardiac output. So even though the heart rate is up, remember the stroke volume goes down because the patient's hypovolemic. So the cardiac output actually decreases. So you can imagine a patient in shock, once you give that bolus of medication, it takes a little bit longer to get back to the heart and redistribute. And that's why there's that delay in hitting peak serum concentrations. Also, because you've lost blood, you have a lower circulating volume. As a result, if you put the same amount of medication in a smaller volume, right off the bat, the concentration, the plasma concentration of that medication is going to be higher. And finally, there is low drug redistribution. Basically, because the patients are in shock, right? They have an increased sympathetic tone and adrenaline pumping through their system. We have increased peripheral vascular resistance. As a result, what we say colloquially is that blood is sort of shunted to the core, to the vital organs, and there's decreased blood flow to the muscle and fat. As a result, the drug doesn't redistribute into that muscle and fat, and what you get is an effect of higher concentrations of the drug that are basically just kind of shunted or pumped from the heart to the brain and the other vital organs. So that has an additive effect on the increased serum concentration. But to complicate things, there are also biochemical changes that happen in shock that also contribute. So, for example, the pH is lower. It's not surprising that patients in shock, most of them experience a lactic or a metabolic acidosis, lactic acidosis. And because of this decrease in pH due to the acidosis, the drugs actually more readily penetrate the blood-brain barrier and get into the central nervous system. Also, practically, when we think about these patients that we fly out and pick up in the field or come to us in the emergency department, most of them have received some degree of crystalloid fluid. Crystalloid fluid actually decreases the concentration or dilutes out the concentration of plasma proteins. And we know that many of these IV anesthetic drugs are plasma bound. So if there's lower or plasma protein bound, and as a result, we have more free drug available. So there's more free drug available that more readily penetrates into the CNS. So, what's the end effect here? It's like cranking up the volume on the effects of these drugs. It increases the amplitude of the effect of many of these agents. And these patients become very sensitive to medications, and the effects are very unpredictable. In fact, in some studies, as little as 10 to 20% of the normal dose of the drug was was able to give the same plasma concentrations as with patients in shock. So you really, really, really need to decrease the dose in hypovolemia in your shock trauma patient. And when I learned this and when I started to realize this, I was like, oh my gosh, no duh, right? No wonder I had had that experience in Iraq, because by giving that patient a normal dose of even a drug that was normally considered safe and hemodynamically stable, was really not, because of his physiological condition. Now, many of you listening to this might say, well, I've heard that before. I've read about it or seen it on podcasts, like here on MCRIT Podcast 30, where Scott discussed this very similar topic. But the purpose here was basically to emphasize or to discuss the underlying physiology for many of my colleagues in the pre-hospital environment, but also to provide a mental model that could act as a guideline to how exactly we should institute this change into our practice. But before I get to that mental model and before I get to how I think we should make those dosage adjustments in the pre-hospital environment, I wanted to bring up one really important issue, which is that I think we need to change the focus of the conversation we've recently been having when it comes to RSI medications in shock. Recently, especially in the setting of trauma, we've been focused on discussing which drug is best. And from the research that's available now, what we realize when it comes to patient-oriented outcomes, there's really no difference whether we use etomidate or ketamine in trauma for RSI. And therefore, I think we just need to shift the focus of the conversation a little bit from which drug we use to drug dose. Yes, yes, I would not necessarily in the pre-hospital environment choose propofol or thiopental, which is not even available in the United States, as an induction agent to pre-hospital providers. But I would focus also on the dosage of the drug I would use, whether it was ketamine or etomidate. And this shouldn't really come as a surprise to us, because Paracelsus talked about this hundreds of years ago when he said, all things are poison and nothing is without poison. The dosage alone makes it so. So where do we go from here? Next, we need to decide on the therapeutic adjustments. And this is where we move beyond just saying decrease the dose to providing what I think is a reasonable mental model to deal with this. So remember, mental models are complex representations that our brain makes that incorporates a lot of information. So, for example, if I say ventilator, you might immediately think of the ventilator that you use on your helicopter or in your ambulance or in your ED or your ICU and all the buttons that are on it. And this is also associated with ventilation strategies, such as the ARDSNet strategy or a Rocky Mountain protocol or whatever. And it's also associated with responsibilities and who takes care of it and how it's actually managed when you have a patient on this. So this is your brain's way of taking a lot of complex information and condensing it down into one representation. And the representation or the metaphor that I actually use when I think about how to change drug dosages for patients in shock is this idea of flow. So I think about cardiac output as the flow of a river. So I talk about, or I think about rather, normal patient flow. And normal patient flow is like patients that come in for routine surgeries and procedures who have normal hemodynamics and respond appropriately to the changes in peripheral vascular resistance and cardiac output that normal induction agents cause. And I think about these normal flow patients as being like a nice, steadily flowing river. Now, when you add or give bolus dose medication, what I think about is I think about the river in Chicago, at or on St. Patrick's Day. And as you may recall, they put this dye in the river to turn it green. So I think about the bolus dose medication as a giant bucket of that dye that you dump in the river. And if the river's flowing normally, that dye redistributes evenly, and eventually, as the river flows and washes it out, and it goes back to normal. But when we think about our patients that are low flow patients, I think about our trauma patients that fall into this category. So, our trauma patients that are in shock and have marginal hemodynamic status or have already decompensated and they're hypotensive, I think about them as this boggy sort of marsh where the water is flowing through very, very slowly. And imagine taking a giant bucket of that dye and dumping it into this slow moving, boggy marsh. It just kind of sits there as this lump of concentrated green and goes by very slowly. And you can imagine this highly concentrated lump or blob or bolus of medication or green dye hits the brain, then you get some very exaggerated effects. So that's not a 100% perfect physiological correlate, but that image sort of sits in my brain and allows me to think about it appropriately. Now, for sake of rounding out the conversation, we could also talk about high flow patients. So these are patients with actually increased cardiac output. So these may be like our patients who are experiencing agitated delirium. They have an elevated blood pressure, they have an increased heart rate, and they are actually like the rapids and the Colorado River. So that's what I imagine their flow to be like. And if you imagine dumping that dye into this river, bam, it is gone instantly. And now, if when I take that metaphor and I actually apply it to clinical practice, I think about ketamine, and it's the drug that I normally use for induction. Still, I realized that it can have its complications, but I'm still a big fan of ketamine. I use it regularly as an induction agent. And so, if I apply that concept of flow to how I change the dose for ketamine, my low flow patients, I actually decrease the dose substantially. I'll start off at about half a milligram per kilogram, somewhere in that range. For my normal flow patients, I'll go with a normal dose of about 1.5 milligrams per kilogram, plus or minus. And then for my high flow patients, actually our patients in excited delirium, I'm looking at more like 2 to 3 milligrams per kilogram IV or the appropriate IM equivalent, which at least in the literature, people have discussed and presented that up to 4 to 5 milligrams per kilogram IM is appropriate for patients in agitated delirium. So I'll throw this out there that anytime I have an idea or a metaphor or a mental model that I'm preparing to apply in the clinical environment, I always pause and think about if it's appropriate and safe to do. And in order to do that, number one, I always go to the source literature and find some scientific evidence at possible that it's safe and reasonable to do it. Number two, I always run it by people way smarter than me. So in this case, when I was in the military, I had trained at the Shock Trauma Center, the R. Adams Cowley Shock Trauma Center in Baltimore, and I contacted some people I know from there, in particular Rick Dutton, who was formerly the Director of Trauma Anesthesia there, a gentleman with a ton of experience when it comes to resuscitation of trauma patients in RSI and trauma, and ran this idea by him. And he hastened to add that yes, you have to be very, very, very careful with the dose of the medication, and you have to reduce it substantially with patients who are hypotensive and are hypotensive trauma patients, and noted that the strategy for ketamine was appropriate, was definitely reasonable. And finally, and I will definitely emphasize this for my pre-hospital brethren, for my colleagues, men and women in the pre-hospital environment. The third thing I do is always run it by my medical director, or at least make sure it's within my scope of practice and within my clinical guidelines. I will not encourage anybody to work outside of their clinical guidelines or state protocols. Now, before I wrap up, just a quick note on a couple things I did not discuss in this talk. One, The concept of resuscitation before intubation. Absolutely. Get some blood going in these patients and the trauma patients, add on plasma, and do what you need to do to appropriately resuscitate them. But just because you bump up their MAP does not mean that it's okay to just go ahead and give them a normal slug of induction drug. Still think about those drug adjustments and decreasing the dose appropriately. 2, push dose pressors. Absolutely, I think they're a great idea to have your push dose epi or push dose phenylephrine available when it comes to trauma patients. I prefer push dose epinephrine. That's what I use in my practice. However, having a push dose agent does not give you license to just go ahead and not think about the physiology and give a normal dose of induction agent. Still use a decreased dose of the induction agent, but it's also reasonable to have a push dose pressor ready as a safety net. So remember, what I think we need to do to help people adapt in very stressful environments and at the same time incorporate critical aspects of pharmacology is 1, understanding the baseline pharmacology. 2, think about the physiology of the patient in front of you. And 3, decide on therapeutic adjustments. But when we make those decisions, we have to give people high fidelity mental models or guidelines that will sit in their mind and they can actually use when their cognitive bandwidth decreases when they're super stressed out. If you're interested in learning more about human factors as it applies to the clinical environment and resuscitation, come check us out on MCRIT. Thank you guys very much for listening to this presentation. If you're interested in following up on some of the resources and references that I used to make this talk, go ahead and take a picture of this QR code or go to https://tinyurl.com/practicalpharm. Thank you very much, and feel free to contact me on Twitter at RecessPadawan or email me at michael.j.loria@hitchcock.org. Thank you guys very much. Take care.